Hello, my name is Hope Rugo, and I'm a professor of medicine at the University of California, San Francisco's Helen Diller Family Comprehensive Cancer Center, where I'm director of breast oncology and clinical trials education. It's my pleasure to welcome you to this discussion on the emerging role of selective estrogen receptor degraders, or SERDs, for treating patients with hormone receptor positive breast cancer. I'm here with my colleagues, Dr. Fatima Cardoso, who's the medical oncologist and director of the breast unit at Champalimod Clinical Cancer Center at Lisbon, Portugal, and Dr. Matti Apro, who's medical oncologist and director at Genolier Cancer Center in Genolier, Switzerland. Welcome to both of you.
Hello.
Hello there.
So our agenda is going to include 3 different topics: the key advances in hormone receptor positive breast cancer for 2021, which patient subgroups require special considerations or treatments in the breast cancer setting, and which patients might benefit from the oral second-generation SERD therapies that are currently in development. Each section will be a short background information and then a discussion from my esteemed colleagues. So we're going to start with the key advances in hormone receptor positive breast cancer for 2021. And you can see here just a flow diagram of diagnosis, surgery, frontline treatment, and second-line treatment in the metastatic setting. We're sort of shortened that adjuvant area there, but basically treatment in the metastatic setting is regardless of menopausal status, with ovarian function suppression being a key step in treatment of patients whose ovaries are still functional. Cyclin-dependent kinase 4/6 inhibitors have become a part of our standard frontline treatment of hormone receptor-positive metastatic disease, given either with aromatase inhibitors or the injectable SERD fulvestrant. And with the survival data that we've been seeing, really are our standard of care, so that we only rarely would consider single-agent endocrine therapy. Our next steps of therapy are often determined by whether or not the tumor has a PIK3CA mutation, with use of the alpha-selective PI3 kinase inhibitor alpelisib with fulvestrant in patients who have a mutation and can tolerate this therapy, and then in patients who have wild-type disease or where alpelisib is either not tolerated or is not available, use of single-agent SERD fulvestrant, combinations with everolimus, and then other sequential endocrine therapies, of course, can be considered in patients who have very endocrine sensitive disease in either arm. And there are no validated predictive markers other than hormone receptor status to determine who will benefit from a CDK4/6 inhibitor or from the addition of an mTOR inhibitor to endocrine therapy. Challenges for managing resistance continue for all of us with understanding heterogeneity, establishing optimal sequencing, and identifying predictive markers. And then the application of selective or specific genomic assessment tools in clinical assessment is something that we'll discuss a little bit more with the integration of relevant genomic data to support our treatment decisions. So let's go on to our panel, the more interesting part of our discussion here. And I'll ask first, Fatima has been very involved in developing guidelines in the metastatic setting, how guidelines have changed in response to recently improved treatments for patients with hormone receptor positive breast cancer.
Thank you, Hope. So obviously, with the consistent data of CDK4/6 inhibitors, both on PFS and especially on overall survival and quality of life, the guidelines have changed to consider these the standard of care for the majority of patients in first line and for a minority of patients perhaps in second line.
So there are still, of course, ongoing challenges when we're developing a treatment strategy for patients with hormone receptor positive disease. What do you see as the primary challenges now, and what new options are really in the front of your mind, Matti?
Well, thank you, Hope. I think that one of the main challenges that we face is the definition of the patients being certain that they are actually HR positive. So therefore, with the recommendation to do a biopsy when feasible. And then we know that there are different courses of disease before you start the first, second, third line. And this is almost never taken into account in the studies. Then what we have also as a challenge in the world is that in different areas in the world, what the patients have been given, have received, is going to be different. So what is valid in a certain study setting might not be valid in the setting in which you are working. So we have to take all of this into account. Are there really any new options right now compared to what was shown in your summary slide? I don't believe so, except that we do have some data that says that in those countries where unfortunately CDK4/6 inhibitors are not available, capecitabine is an option in the postmenopausal patients.
That's a really good point. And in referring to an interesting study looking at capecitabine versus endocrine therapy with a CDK4/6 inhibitor. But that gets to our next question, which is really how we define optimal sequence of therapies for individual patients. It can be very difficult. And how do you think we should be defining this, and what improvements could we see, Fatima?
So I think that the optimal sequence will not be answered by trials, by traditional clinical trials, because it would mean to do a trial with several randomizations, and that is almost impossible to take through. So I have hope that what we call real world evidence, and particularly the application of artificial intelligence models on very large amounts of real world evidence would help us define what is the best strategy, if not for the individual patient, at least for a group of individuals with very similar characteristics. Until that moment arrives, I think the best we can do is follow the evidence from the trials and provide, as you showed in your summary slide, what is now the sequence of approved therapies. And as Matty said, not all of them are available everywhere. And the most important take-home message is that even if you don't have the targeted expensive agents, the best treatment for this subtype of breast cancer is endocrine therapy, not chemotherapy.
That's a really good point. And I think, we're certainly looking for the development of a number of new agents, both in the endocrine setting. We'll talk more about the oral SERDs, but also selective androgen receptor modulators, other ways of targeting ER, which I think are quite interesting, and then targeted agents like AKT inhibitors. So what role how do you use biomarker testing? Is there a role for biomarker testing in the first line setting, Maddie?
Today, unfortunately, we don't have data to show us that we can use biomarker testing in the first line. But I think this is part of the definition of the optimal sequence. In spite of the shortcomings until now of all the data that tried to give us a clue of what is the biology of the disease in this particular patient that we are treating, knowing also that the metastasis in the bones can have a different biology from metastases in the liver, which complicates issues also. We should not give up on that. We should do more and more studies trying to define on the actual tumor that the patient has, not trying to define what the patient has based on what the patient had at the initial presentation of the disease, which is also something that has been done in some studies, which is completely wrong. So biomarker testing on the patient's tumor as it is something that we should go for, and we will be discussing some examples where we know that there is a clear definition of a drug depending on what is going on in the patient's tumor at that point in time, and maybe how it has changed because of previous use of a sequence of drugs.
Yeah, I think that's a really important, incredibly important point. And sometimes, if you have bone material, for example, from an initial diagnosis, that may be the exactly wrong tissue to look for biomarkers also because of the decalcification. One of the issues about the challenges in a treatment strategy for patients, of course, now is that we've seen survival data with CDK4/6 inhibitors in the first and second line setting, which has been really encouraging. So does that help to encourage providers to use these agents in an endocrine approach, even for patients who have visceral disease? We define visceral crisis, but sometimes it's hard to convince people that hormone therapy is the right step, even though a patient has liver mets or lung mets? Fatima?
So I think it's important to understand what exactly is visceral crisis. And when we say visceral crisis, we mean that there is organ failure. And in those situations, we still do not have sufficient data to go with other option than chemotherapy. But I'm convinced that perhaps we have a powerful enough combination to challenge some of these situations. But until we have data, I don't think that we can do that. I think the powerful overall survival data has certainly, I hope, provided strong evidence for those who are still using chemotherapy as first-line option, that we have never seen this overall survival data with any chemotherapy agent. And so hopefully the percentage of people that are still using chemotherapy as first or as second line will decrease more and more.
Yes, and it was encouraging, certainly in Mona Lisa too, that was seen regardless of visceral disease and in the de novo patients. So really encouraging that I think supports what you are mentioning. So I think with that discussion and excellent contributions from both of you, we'll move on to our next topic of discussion. We'll move on to our next topic of discussion, which are looking at patient subgroups and what considerations and treatments we should be discussing based on different patient subgroups. And of course, we're defining patient subgroups differently all the time. Certainly, we have the standard IHC with hormone receptor and HER2 status, now PIK3CA mutation testing, which can be obtained with a single test or as part of a more broad NGS, germline mutations, which of course, now that we have effective therapies, is something that we really try and encourage in metastatic disease. PD-L1 expression for triple negative breast cancer to determine eligibility for checkpoint inhibition. We also use patient-specific factors such as the biologic age, menopausal status for endocrine therapy, although I think we don't take that into account much anymore, except for using ovarian function suppression in patients who are premenopausal. And then psychological factors, I think socioeconomic factors we've touched on end up being important, even though we wish they weren't. And then, of course, patient preference and therapy availability plays a role. In terms of the clinical history, it's important to understand comorbidities, performance status, organ dysfunction, and as you talked about in immediately life-threatening disease, the need for rapid disease and symptom control, which is quite rare in hormone receptor-positive disease at presentation. Disease-free interval also plays a role, as well as response to previous therapies and toxicity. And then, of course, tumor burden plays a role in need for rapid disease and symptom control. One area that's not listed here, but is, I think, of interest is intrinsic subtyping and whether or not that will ever be something that we want to understand better to define tumor biology and potentially appropriate treatments. We've seen HER2-enriched subtype might benefit from CDK4/6 inhibitors specifically, and then understanding the basal-like group of hormone receptor-positive disease. So let's go on to our panel discussion. And this, of course, is a very complex area, but we're interested in what factors are the most important to assess and how we would assess them when we establish a treatment plan. So we talked about, first, second, et cetera, line, but what are the primary risk factors that you consider, Maddie, when you're looking at a patient? And when do you get NGS? And should everybody have NGS?
I think that the first risk factor that I look at in the patient is who the patient is and what has been the course of the disease. I think that is extremely important. The patient that presents with rapidly metastatic disease is completely different from one who has been off treatment for years and then suddenly has a few metastases. These are completely different patients, and you start to think in a different way. And of course, nowadays, we don't have a real choice based on the biology, except when we get to the second line. And this is just to say that in that setting, I don't see why we should be getting NGS. This is something that should be, in my opinion, reserved today to settings in which this is part of a study setting where we're collecting this data, but we have to look in some patients for a specific changes in the tumor in order to apply the appropriate treatment.
And Fatima, with that under consideration, would you get NGS in plasma or tumor tissue or both? Do you only get the testing once, or do you think sequentially it could be a benefit over time?
So personally, I think what I would like to see, and I think it's being developed, is like a breast cancer specific panel where we would evaluate the markers that can have, that are actionable for breast cancer. And in particularly here, we're talking about metastatic breast cancer, not the full genome NGS, because at the moment, the clinical trials that evaluated the role of doing such a broad NGS have not shown any benefit and have not shown to be better than just guessing based on our knowledge what would be the best options. Having said that, and regarding if it's plasma or tumor, if I can do this breast cancer specific panel, I would go for the material that would allow me to see the best markers, and possibly, in my opinion for the moment, would be tumor tissue. But of course, it's much harder to obtain serial tumor tissue biopsies, and so that's where I think the promise of doing liquid biopsies and using plasma instead of tumor tissue, I would like to see that promise fulfilled, so that we can have a serial evaluation of the biology of the disease. Like Matti said, it's important to analyze the tumor as it is at that moment in that patient and not as it was. So hopefully we will get that much better than we can do it at the moment.
So yeah, I think that's really important, and both really important points. And so, Matti, what are the most important mutations that you consider when you are developing a treatment plan? And do you care about what the ESR1 mutation status is?
Well, today the ESR1 mutation status to determine the first line approach, I don't think we have enough data to say how important it is. We know that there's a high proportion of tumors that when exposed, for example, CDK4/6 containing combinations will develop an ESR1 mutation, and then we have to start thinking of switching, and this is to other types of approaches. Otherwise, of course, what we want to consider is PIK3CA, and for the rest, today I think it's part of research, or maybe I missed something.
Yeah, well, there are certainly, we know that, for example, lobular cancer has a higher number of HER2 somatic mutations, and there is a small ongoing randomized trial with neratinib that will be interesting to see. We know that there's some efficacy and also PARP inhibitors in some of the somatic BRCA1 and 2 mutations. So unfortunately, those aren't sort of established, but there's certainly efficacy. What do you think about that, Fatima?
Well, I think that we have a bulk of evidence now regarding ESR1 mutation status. I think maybe the issue is more on the technical availability in the different centers and in the different places where patients are treated. Because I think what all the data shows is that in the presence of a tumor with a lot of ESR1 mutation, a aromatase inhibitor is not really the best option. So I think that helps us in the choice, particularly, as Matti says, not necessarily the first line, but the second line. If you come from someone who was treated with an AI and a CDK4/6 inhibitor, and if you test and you have ESR1 mutation, then perhaps you should not go with another AI. And I know that becomes very complex in certain countries because, for example, everolimus was studied with an AI, but you also have data with fulvestrant. So hopefully the regulators would allow us some flexibility on changing the agent that we combine with the endocrine agent and the targeted agent.
No,
If I
yeah,
may, Hope,
go
intervene
ahead.
in what Fatima's just said, I think one of the issues that all clinicians face is this gap of understanding between us, the research we have done, which is not according to the regulatory guidelines. And we need to establish a better dialogue between the regulators and the researchers.
It's definitely true. I mean, the idea of using a less effective endocrine partner because of the phase 3 trial, even though phase 2 studies have shown similar efficacy, seems rather wild, but we see it all the time where we are required to use exemestane with everolimus for that very reason. And I think that, we also may see it with alpelisib as well in certain situations where a patient's cancer has already progressed on fulvestrant, perhaps given in the first line setting.
I think we can all,
I
think we can all make a plea for the regulators to understand that we cannot repeat all the trials with the different combinations of endocrine agent and targeted agent, and that we need flexibility on that.
I think real world data may play a big role there, where maybe doing single arm studies in the right populations and comparing it to real world data could be helpful, or at least using a phase 2 setting. Certainly, sequencing therapy is important too. And we talked a little bit about that before. And I think you guys have addressed this mostly, that you really try and optimize the most tolerable therapy, followed by ongoing treatment options. Would you say that's correct?
Not only most tolerable therapy, but the therapy that the patient understands might not, unfortunately, change the survival, but might bring some improvement in quality of life.
I think that's an excellent point. We definitely have to consider quality of life a lot in the metastatic setting, but delaying chemotherapy seems to be also important, but it depends a lot on how you tolerate the treatment that you're giving, which may be worse than chemotherapy in some settings. So. So we're going to go on to our third section here of talking about which patients might benefit most from the oral second generation SERD therapies that are in development, of which there are many. It's sort of like alphabet soup, actually, at the moment. And I'm going to list them here because I think it's helpful to have the names. We have fulvestrant, which is, of course, the injectable SERD. And this drug, although initially approved, was approved at the wrong dose. And we figured out we had to do an induction and a higher dose. But we do see injection site pain. I think that's probably the biggest issue that our patients complain about, and needing to come to our centers once a month at specific time periods. It's clearly a very effective agent, can be combined with CDK4/6 inhibitors and PI3 kinase inhibitors, AKT inhibitors. Amcinestrant is an oral SERD that's a selective ER alpha inhibitor, and this promotes transition of ER to an inactive conformation. There are a number of studies that are being done for registration. AMIRA-3 is the first one in the second and third line setting to look at efficacy in resistant disease. And then elacestrant is another agent that's completed accrual to a phase 3 trial. And we're looking for results from this too. I think that these are the two trials that may lead us in the soonest time period to regulatory approval. Elacestrant induces degradation of ER. And all of these agents, including the next ones I'll talk about, have demonstrated efficacy in ESR mutant and CDK4/6 inhibitor resistant models. The other oral SERDs that are in development include giredestrant, which competes against the estrogen receptor, or competes against estrogen for binding, and creates a conformation in the ER ligand binding domain. There are a number of studies, including in combination with CDK4/6 inhibitors. Camizestrant is a selective non-steroidal pure ER antagonist, so a little bit more unique in its mechanism of action. Also has studies ongoing in the early phase setting and in phase 3. And then there are a number of other emerging therapies that are listed there on the right. And then the early stage data updated from ESMO 2021 is listed here. I won't go through in detail, but all of these studies have indicated that these agents are effective even in patients who've had prior fulvestrant and with ESR1 mutations. And then a neoadjuvant study with giredestrant showed superior anti-proliferative activity compared to anastrozole. And I think that those are the really major updates to note. So let's talk about some of the questions and discuss the oral SERDs. And of course, what's on all of our minds is when are we going to see the results of these data? And what kind of data do we need to want to use oral SERDs? So what do you think will lead to approval? Do we need to have something that's just as good, or does it need to be superior? And how will the approval of a SERD impact our use of endocrine therapy in patients with metastatic hormone receptor positive breast cancer? Maddie, do you want to start with that?
Yeah, let me say something nasty about regulators again. If regulators are serious in what they have been telling us, that they will consider patients' quality of life, and if from our experience, we know that fulvestrant is a fantastic compound, but the patients complained about it. I have patients actually refusing to have it because they say, what, these injections? No, my cousin had that stuff, no way. Having an oral agent, provided that the overall toxicity profile is not that different, that they are indeed as tolerable as they claim to be right now, will make a huge difference. And even if they don't show a clear advantage above the available agents from the perspective of progression-free survival, not speaking of overall survival, but in those studies that have an overall survival potentially containing RMITs show the same data, I think that we should have these agents made available to us. Another question is then, at least in Europe, it's approved, yes, but is it going to be then reimbursed in the different countries? Because HTA analysis is another issue.
So, yeah, go ahead. I wanted to ask you a similar question, Fatima, and also just have you talk about whether you would replace fulvestrant with these agents if there were positive trials.
I think that the path to approval has been chosen for these agents is quite different. And I think there was a decision to be made, I suppose, that you could either go head-to-head with the fulvestrant and show that they are not inferior, and then we would have a huge discussion about non-inferiority as we have in other settings. But for me personal, I think if we can prove that they are as effective as fulvestrant and that the toxicity profile is acceptable, because it is true that pain in the site of injection is very common, but it's almost the only side effect of fulvestrant. Otherwise, it's a very well-tolerated drug. And the benefit of an oral drug has to be balanced also sometimes with higher toxicity, GI toxicity mainly. Some of these agents worry me because of potential cardiac toxicity, potential eye toxicity, ocular toxicity. So I think we need more data to see their tolerability. And if in terms of efficacy, all I need them to prove is that they are as good as fulvestrant, and that would be sufficient to use them.
Yeah, it's interesting because I think that most of the trials are based on superiority, and that will be what's required by the regulators. And I think Maddie's point and your point are really important, although, mostly the studies have suggested they're pretty well tolerated. Being nauseated every day or having diarrhea on and off is probably not advantageous either. But I think you talked about the fact that oral is important. If they're more effective or, for example, are able to counter some ESR1 mutations are actually associated with resistance to fulvestrant and certainly a shorter PFS, even with fulvestrant. Would that also be an appealing reason to substitute fulvestrant with these oral SERDs?
In my point of view, yes, because I think more and more our standard of care for the first line setting is going to be an AI plus a CDK4/6 inhibitor because they are both oral, easy to administer. That means that in the second line setting, we will have to deal with ESR1 mutations, and we will also have to deal with resistant mechanisms to CDK4/6 inhibitors. So some of these agents are being developed as a potential way to overcome those two resistant mechanisms. So I think that if they can prove that, they would certainly be a favorite second line.
And so, Maddie, what would be the situation where you would, for example, use a new oral SERD instead of an AI in the first line setting?
Instead of an AI in the first line setting, if I only had the demonstration that I can use some of the methodologies to look at the ESR mutation validated in that setting, as we discussed earlier, I think that would certainly be an indication. Otherwise, I think that we have to accept that we have an excellent first-line combination that is made available, and we shouldn't move from that unless we have this evidence. And I would keep then these agents for second line instead of fulvestrant, provided that they have the characteristics that Fatima so nicely summarized. And once again, I said, I have had several patients refuse fulvestrant because they can't think of injections. They're just thinking that injection is the next step to the grave. It's awful.
So perhaps we can have an exception there, Matti. I think, for example, someone who has a relapse while on an AI, I think that in that situation, we would like to consider fulvestrant or an oral SERD if they prove to be
No, of
equal.
course. I said if we can't use an AI and CDK4/6, we have to have a good reason. Of course, the patient has been on AI. We would not go ahead with an AI and CDK4.
And some of the studies are actually directly comparing an oral SERD with a CDK4/6 inhibitor to an AI with a CDK4/6 inhibitor, sort of like the Parsifal trial did. And I think that will also be very helpful for us, although we're going to be looking at shorter term endpoints. I mean, it's going to take forever to see survival differences there. Hard to know as we continue to improve on what already is remarkable survival in this patient population. One last question about, how we're going to move these drugs into maybe the early stage setting. Do you see a path for that, given the fact that there was a little bit of neoadjuvant data, difficult setting for ER-positive disease? Would this be something where maybe when patients had ctDNA showing an ESR1 mutation, you would switch them? How would you use it? Fatima?
Well, there is a study ongoing exactly looking into that. I think we always wanted to move fulvestrant for the early setting, and we were not very effective in doing so because of the route of administration. So I think that there is hope that we can go and study these agents in the early setting because they are oral.
And in the early setting, you said ER positive is going to take a long time to observe. We shouldn't forget that we do have biological means to look at changes in the tumor cells, and we have had some wonderful examples coming to us from Germany.
Absolutely. And I think it will be really interesting as we see the CDK4/6 inhibitor abemaciclib make its way into the early stage setting over the next few years, that what we use with hormone therapy will also be really important. I want to thank you very much for participating, Maddie and Fatima. These comments and discussion was so interesting, really great, and brought up a lot of the important points in terms of how we're treating patients today and what we're looking for in the future. And thank you to the audience for watching this discussion about the emerging role of SERDs in treating hormone receptor positive breast cancer. We hope this has been useful for you.